Well, we're so pleased to have Dr. Bill back with us. Last year, almost exactly a year ago, Dr. Bill Buchholz talked to us about the pandemic, and boy, was that a different world. And this time he's going to give us a quick update, probably just a quick 10-15-minute update on the pandemic, because that's still top of mind for many of us. And then he's going to talk about a really important topic that I completely misunderstood. And I'm sure you're going to gain a lot of information from that. So Dr. Bill Buchholz is a medical oncologist, was educated at Harvard University and Stanford Medical School. He's been practicing in the Los Altos area from 1978 until 2014 when he retired. Since then, he has continued to lecture to professional and lay groups about advanced care planning, the End-of-Life Options Act, physician-aided dying, and conducted workshops to help people before they become patients have more control over the medical care they receive when they are facing potentially mortal illnesses. He serves on the Senior Commission of Los Altos, the Medical Ethics Committees of El Camino Hospital and Santa Clara County Medical Association. He was chosen as a Changemaker Fellow at Los Altos United Methodist Church, and his project was Creative Aging. Personally, I know Dr. Bill for his kindness and for his generosity with his time and expertise, which he's going to share with us right now. Over to you, Dr. Bill.
Thank you very much, Wesley. I enjoy looking at my audience, even if it's a stationary picture. I'm going to ask a couple of things of you. While you're listening to the talk, think about ways that this will impact your particular enterprise. It's important that this be useful information in a practical, operational sense. I have as of February 11th, the week of February 11th, the cases and deaths in Santa Clara County, 502 and 4.6, and these are both per million people. In the country, the cases are 614 and the deaths are 7.7. So even though Santa Clara County has decided not to lift the mask requirement quite yet, we're still way ahead of the rest of the country. First of all, the good news, and then I'll give you some more good news. The incidence of Omicron and in general COVID infections is decreasing. The reason for that decrease is the immunity granted by either vaccination and booster or having had COVID is approaching the level where we get herd immunity. When there is herd immunity, and I'm referring to the herd as applied to cows, the incidence of encountering someone with COVID becomes low enough that the disease becomes endemic, and that's from the Greek meaning native. So it's endemic. It continues to be active in the population, but the frequency of active disease, i.e. symptomatic disease, is low enough that it becomes not so much a total public health urgency. The deaths and ICU hospitalizations, which have overwhelmed a lot of the medical systems, is almost exclusively from unvaccinated people. The number of people who remain unvaccinated is probably close to 25%. So these will always be the petri dish that can be infected and hence be the start of a new variant. viruses mutate frequently. And so variants are become obvious only when they have a selective advantage in the area of vulnerable people. Omicron was very, very, very contagious. It approached the contagiousness of measles, which is like 95%. But the severity of the disease, fortunately, even for those who are unvaccinated, is not nearly as bad as the previous variant, Delta. And by the way, if anybody is tracking these on Greek alphabet, they skipped quite a few letters between Delta and Omicron. Herd immunity is roughly 85% immune of the population. So 85 out of 100 people will have some immunity and be resistant to catching Omicron. And this then offers protection for everybody. Only 75% of the country is vaccinated. By the way, those of you who are in Santa Clara County, we're over 85%. So the mask allowance, the pardon, if you will, is still appropriate. And because the decisions are made both on a national and local level, the data used to make these decisions is not entirely uniform. And so there can be a difference in the local recommendations and the more widespread. It's all based upon scientific information, validated information, if you will, peer-reviewed information. So it's trustworthy. There are a lot of mathematical projections of what's going to happen next. These obviously are based upon some assumptions, and they do consistently, and they're probably, I saw at least 15 different models, all showing a rapid decrease over the next several weeks. So the trend for fewer infections will continue. The time between infection and ICU or death is roughly a month, so that the number of deaths and hospitalizations reflect what was happening back at the end of January. As I said, epidemic means that the herd immunity is sufficient to decrease the chance of anyone becoming infected. And what that's going to mean in the good side is that people are safer. What it's going to mean on the bad side is that people who have chosen not to be vaccinated, or for other reasons have not been vaccinated, they're going to have a get out of jail free card. So the people that you see not wearing masks may or may not be those who are indicated as these recommendations apply only to those people who have been vaccinated or immune from having been infected. So look forward, folks, to a lot of continued conflict between people and organizations that serve them. So what this means for you, oh, by the way, the KN95 masks are the best protection along with 6 feet. And for those of us who use metric, that's 2 meters. The double masking is detectably better than even just a K95, KN95. So they'll put a surgical mask, which is not very good, by the way, and then put the KN95 over that. When I go in public spaces where there are people I don't know, I will be double masked. I am of the same age that the clients that you serve. In case you didn't do the math, I'm 76. Fortunately, I'm very healthy and I intend to stay that way. There's going to be some interest in repeat booster shots, and that frequency hasn't been determined yet. There are data showing a fall off in effectiveness at 5 months, let's say. The least fall off is with a messenger RNA, Pfizer and Moderna vaccines. So there are not yet data that would suggest if you've had your booster, your first booster, when that immunity will drop usually from the mid 90s to something less than that. Again, a lot of these decisions are being made on economics also. So there are several masters being served. Again, I don't know how this directly affects your businesses because you are in vastly different ones. But certainly, it will be useful for you to be mindful that a lot of people are going to continue to wear masks regardless of immune status. And so it would be, if you'll excuse the expression, politically and politely correct to let people know that you are aware that you want to protect them. And so I'm certain any of your employees that go into homes are already doing that. Any questions now? And please unmute yourself if you have a question.
I do. So okay, so I had COVID and my husband had COVID, but then his physician said, don't get the booster because he was going to react probably to that booster. So is that, I mean, what do you do when you've had COVID? Do you wait the 5 months and then get a booster? Like, how is that all going to play?
I have not seen any data that show that there are increased incidents of side effects after people who have been infected. So I'm not sure how that physician came to that conclusion.
Yeah, I don't know.
It is clear that vaccination provides a much longer protection than infection.
Okay.
So I would say, go get him, Tiger.
Okay.
I have a question.
Yes.
People are starting to get together indoors, sometimes with the use of rapid tests and without masks. How do you feel about that?
Rapid tests do have a higher false negative than the PCR sent to the lab ones. I have a close circle of friends whose behavior I know, and also their vaccination status. So I feel quite comfortable with that. I have an article that goes over vaccinations in general. And I didn't send that to you, Wesley. Wesley has several pieces of paper or pieces of electrons that are useful for you, and I will send the one on immunizations and the pros and cons of each kind. Does that more or less avoid your question, Bella?
Yeah, it sounds like if you know that the people have been vaccinated and are behaving more or less carefully, you'd feel pretty comfortable with that situation.
Yes.
Okay, thank you.
I'm going to go on to the next topic unless there's another pressing question.
I do. Something that I've been concerned about.
where-
Oh, sorry, this is Shauna. I'm around here somewhere. So we know that the vaccine, having the vaccination doesn't stop somebody from carrying it, right? Does it minimize a little? Does it not at all?
Oh, yes.
Like,
No, it decreases the chance of being a quote breakthrough infection sizably.
okay, but
It's
carrying
not,
it to other people?
It's not bulletproof.
Right. I think, okay, so, and I'm not even talking like if I were to get it, right? Like if I'm around a group that I know and then I go to a client and I'm being careful, but I'm vaccinated. Am I still, I could be a carrier still,
Yes.
but is it minimized because I'm boosted at all or no?
Oh, yes. If you
Okay.
have been vaccinated and boosted, then your protection is excellent. It's not, as I said,
Bulletproof.
bulletproof,
Right.
but it is safe to be around the general public.
Okay.
For some of the clients that you serve, no,
Okay.
because they have comorbidities that if they did get ill, it would not necessarily be a mild case.
Right. So I have to just still assume that I could be a carrier to at least my older clients, and that, you know, just got to keep them protected just as if I had never had anything.
In this case, specifically, home testing would be useful for you.
Mm-hmm. Oh, I had those. Okay.
They are becoming a little less expensive, and you just have to use them according to the directions. And it does
Right.
matter if you read them at 15 minutes, not 17.
Right. Okay. Okay. Thank you.
I have a question.
Yes.
Beyond being around someone who is known to be infected, what would you say is the number one indicator that you should get tested, possibly either a rapid test or a PCR?
The kind of contact you may have had, if the known person is walking in your neighborhood, not a problem. If you're there at your monthly poker game, it's a problem.
I mean, like maybe symptom or just outside of interacting with a known person. What is a good indicator I should get tested? So striking that one off the list.
Your anxiety. I mean, just realistically, I would be foolish to say an absolute no or absolute yes. But again, we're dealing with statistics. And as Mark Twain once said, there are lies, there are damned lies, and then there are statistics. So I offer that as a little bit of levity. And I'm going to go on to one of the central parts of my practice. As Wesley said, I'm a retired oncologist. And also, I've been a consultant for hospices. I have been the MC for a lot of the Clara conferences. So I'm actively involved in end-of-life issues. I'm also a physician working in a hospital. And so I can see what goes wrong. I have my advance directive and it says no intubation. Well, where is it? Oh, it's in my safe deposit box. Unless the physicians have a document immediately visible to them, legally signed, etc., they can't accept your word, and they won't. And so they will act in accord with the immediacy of a problem. They have some reasonableness. So if you're just celebrated your 100th birthday, they're probably not going to do a lot of chest compressions because they would leave you with, what is it? I guess there's 12 ribs, so that would probably give you at least 12 fractures. But a lot of the time, there can be the daughter or son from Toulouse or Gainesville or wherever it is, who rushes in in spite of the existing advance directive, and I'm going to distinguish between an advance directive and an advanced planning, and screams, "Save him, save him, save him." And that person has a very loud voice and is being kind of obnoxious there in the emergency room. And that will still give doctors some concern. Let me go back and say, an advance directive exists if you have named someone who will speak for you if you cannot speak. It is signed and witnessed. It doesn't have to say anything about what your wishes are. Though I, as a doctor, thought it would be really useful for my family, as well as my physicians, to know what I really want. And there was an article in the New York Times recently that will be shared with you about a woman who had absolute, under no circumstances do I want to be intubated. She was in the hospital with pneumonia. And the doctors felt that she had a very good chance of being successfully treated and returning to her pre-infection state. And so they did intubate her. She got off the respirator, and she was immensely grateful for them disregarding her original, very forceful statement. And that's the problem we face, is when people will write down what machines or procedures that they don't want. They're writing it down while they're relatively healthy. The advance directive only applies when you can't speak for yourself. So the way that I've circumvented this, because I don't know that my personal physician will be there in the ER if I have a stroke or whatever. So I wrote it in terms of my values. So if the care team knows my values, and my family knows my values, and they both agree to follow them, then I feel that I have less chance of anything can happen day. The title of one of the articles I wrote is Repealing Murphy's Law, because I can tell you, Murphy walks the halls of the hospital a lot. When I thought about my values, which by the way are different from my wife's, and I thought about the different things. Could I, if I were a quadriplegic, if I had mild dementia, things that can happen, a stroke that would leave me hemiplegic, and possibly decreasing my ability to communicate. So these are things that happen. So the way I expressed it, and you'll get a copy of the addendum to my advance directive, I used 5 wishes because it was useful, but it by no means is complete. Then I'm going to say something about attorney drawn up advance directives. I'll say right now, when an attorney draws up an advance directive, it's an attorney thinking legal. Their impeccable prevention of any legal challenges is there, but they don't necessarily understand that in the hospital, the medical system, rather than the legal system, makes the rules. So you have to know kind of how do doctors think and how do they act? So the way I wrote my directive was, if I am able to give and receive love and be self-aware, cognizant, then if I can return to that state, then my life is worth living. Also, I know that in the immediacy of a problem, that the outcome is not necessarily known. So I worded things as if I could be temporarily put on life support. But I then set up a situation explicitly about, let's say, pneumonia, or let's say a stroke, and said, if 2 or more physicians, including a neurologist, say that I have less than a 5% chance of returning to the status quo ante, then I do not wish life support. And that after, I think I used 1 month, if it does not seem like I am going to be able to return to that status, then I wish life support stopped. So that's thinking like a doctor, because doctors, well, they doctor, which means that whatever they studied, that's what they want to do. So carpenters have hammers and doctors have scalpels. But and I am not really dinging my surgical colleagues. They know me inside and out. A chance to cut is a chance to cure, is one of the phrases that doctors have used, perhaps in jest. But it indicates, just as an oncologist with lots of different kinds of chemotherapy, excuse me, will feel, well, we could do this. And that is the most dangerous statement a doctor can ever say. Particularly if there's looking for low probability interventions. So second line chemotherapy for some cancers can be quite curative. But if you're on the fourth line, it's not going to work. At least up until I retired, I don't know of anything that would have worked. So you have to think about what is your value that makes your life worth living. For my wife, Susie, who's a PhD psychologist, she felt that as long as our daughters want her kept alive, she would consent to life support. So it punted the decision to the daughters, who are both wise and medically trained. At least, well, one's a nurse practitioner, and her husband's a nurse practitioner in oncology, which I don't know how that happened. So it has to be your value. And so in the conversations that you might have with clients or with your friends, it's a pretty intimate conversation. And it's best framed as empowerment. Because when you get right down to it, it gives you the power to receive or decline treatment when you're not there to say, time out. And so I would invite everyone to think in those terms. And the case in the New York Times article suggests exactly why that's true. Now, in your own businesses, you encounter people sometimes in roles that are pretty mechanical. So if you're simply supplying oxygen, you may not want to start a deep conversation about end-of-life care. But if you are having caregivers or caregivers yourself, then raising a hypothetical can be, if there's a trust relationship already established between you and the client, can be immensely powerful opening for you as well as that other person. Because when you get to the rawness of people actually confronting the end of life, there's a space that opens up that is filled with wisdom and with the ability to be the very most honest and best person that you can be. And that has been one of the greatest joys of my life, is having these conversations with people to make sure that they get to be them based upon who they wish to be, no matter what. And I've had patients who demanded chemotherapy long after I didn't want to give it. And this was absolutely consistent with who they are. So I honor the person and not the path report. And so I don't know how you would imagine taking the role of nudge not nudge, nudge. And how it will affect other lives. And if you have these conversations just with your colleagues and your friends, if it's indoors, check their vaccination status. If it's outdoors while you're walking, it's probably okay to be mask off. But it's real. And it makes a huge difference, because I have seen people who did not take the time because they didn't want to confront the circumstances where these kind of documents would be used. And that's a place where Murphy can fling feces at the air conditioner, because it does hit the fan. I'd like to take any questions, because I know this has been thought-provoking. And if you're not able to formulate your question right now, you certainly have my contact information, and you can send me an email. Louise?
Hi, can you send us a copy of how you write your Advance Directive? That'll be awesome.
If you'll excuse the expression, it's in the mail. The email.
The email, great. Thank you so much.
Or already.
Oh,
Patricia? You're muted. You're muted. Patricia, you're
Okay, got it now. Got it now. Got it now. Thank you very much. I had other things interfering in this whole thing. I think it's all about quality of life, and what your quality of life is going to be if you're resuscitated. I think it's really important to think about that. And I have been, of course, in the 16 years that I've been involved in the work I'm doing at the moment, very much involved with sometimes having to help people make a decision. A lot of it depends on ethnicity and your values through your particular way of being brought up and where you were brought up. And we need to be respectful of those. But we also need to understand and explain that what life's going to be like if such an incident happens. And I think that you may not have your Advanced Healthcare Directive with you, but you may have your post with you, which says quite categorically what you want. And you're doing that hopefully at a time when you're able to make logical and sensible decisions. That's very important. And I know you're going to say something about that. I know.
Mark that statement. Go ahead. Continue.
So my concern here is you can't always show your Advanced Healthcare Directive. It is not where you have it handy. You don't tend to carry it around with you. And unfortunately, many people do not let the hospital know about it. And in a time of crisis in an emergency room, I have been asked what the wishes are of the client because they haven't looked at it on the computer or whatever. And so you need to be aware of what's on there. And having a post does give you, I know it's debatable, but it does give you your doctor some idea of what your wishes are. Why would a doctor want to sign that if it was not going to be of any darn use? I know it's there for the paramedics, but sometimes people carry those with them because they carry them with them. So really, it does boil down to.
One, I have been in circumstances where, because the post was signed by a doctor who did not have privileges at the hospital, it was not deemed to be valid. Two, I have myself made sure that in my medical chart, I work mainly out of El Camino, and seen for myself where it is and how to get there. So that I think that the safest place is going to be in the hospital. And since some people wear both belt and suspenders. I would recommend having a little thumb drive, UBS drive on your keychain, so that that can be plugged in immediately, and that your health information, including advanced care directives. So that's the best I know how to recommend. And a pulse can be misused as simply a way of a doctor avoiding more in-depth conversations. So I know a primary care doctor who insists that all his patients have pulses, whether or not they are likely to have any reason to need them in the next 6 months. So you know why we have 50 shades of gray? Because nothing is ever black and white. I don't see any other hands.
Louise, I think you had your hand up for a second.
Oh, I already got, Doctor
Oh, you
already
did?
answered the
Okay.
question. Yeah.
All right. We still have a bit of time. Bill, do you want me to put up your Advance Directive Appendix D? It might be useful before.
On the screen?
Yeah, is that okay?
Absolutely.
I think this is the one thing that I think most people really don't understand. And let me see if,
You have to unpin me.
Oh, yes, I will.
Actually, I wanted to be lavaliered, but you pinned me instead.
Okay. All right.
I actually have one more question. So there are like what doctor say, the DPOA bill by the lawyers, and there's another one like Advance Directive provided by hospital system like Kaiser. So which one should the physician follow when the family present both documents?
The DPOA simply designates the person whom you wish to speak with you. And you know what's the most important part of that is? The conversations that you have with your family and with your doctor. Because you really want to know that that doctor will observe and back you on the way that you want to do things. And some doctors won't. And by the way, if you're admitted and have surgery, the Advance Directive and so forth is inactive while you are on life support, because that's, if you have anesthesia, that's life support. And sometimes the doctors don't immediately reverse that order, and so that you are held captive.
Well,
Can you put it up?
I'm having trouble. I'm sorry. I'm gonna have to.
You'll all be able to read it specifically because it'll be sent out by email. And again, it's doctor words because the people who are going to be making a lot of the decisions are doctors. So if you are dealing with someone who speaks only Urdu, you really want to have the instructions in the language that the physician can understand.
Noah, you got a question? Go ahead.
Yeah, hi. Thank you, Dr. Buchholz, for this presentation.
You're welcome.
So I have a remark, or a question about something you said earlier. So if you had a patient that you thought the second line of chemotherapy was sufficient, like you wouldn't recommend more, and yet that patient still asked for a fourth line of chemotherapy, I understand you respect the patient and that's what they want, and you want to be true to their values. How about your values? I mean, how do you reconcile giving chemo or do you do that? If somebody asks for a fourth and they already your patient.
I ask them, are they fighting for their life or they're fighting not to die?
Mhm.
A lot of people who want to continue treatment are doing it out of miracle searching. And and I can have a conversation with them about if you are trying to avoid dying, then are you living fully right now?
Mhm.
Because if you're not living fully right now, you're already dead.
Mhm.
And so it's a conversation. And would I give that? If I think that the person is just trying to beat death,
Mhm.
I will suggest that they get a second opinion.
Mhm.
And in the hospital, there are protocols for people asking for, quote, non-beneficial, i.e. futile treatment.
Mhm.
And it is not required that that be provided.
Okay.
But that's an ethic. Yes, you need an ethics committee consultation, which I've been on.
Yeah. Okay. So you would not.
Correct.
Okay. Okay. Great.
I would give that opportunity to another physician.
Okay. That's great. Okay.
A competent physician.
What kind?
A competent.
Yeah. Okay. Yeah. Okay. I would thank you for that. Yeah. I would also like to add that I had a personal experience with several family members about advance directives. And I would like to point out that it's a really very fluid process. That even, and I had an uncle like a couple of months ago who went in because he was having chest pain, and he tolerated that for 2 days, and then he went to the emergency room, and then they admitted him, and then they did some testing, and they said it's a mild heart attack. Okay. And so he's a 75-year-old guy with a history of diabetes, and he had multiple stents before, and they started to do the catheterization process, and then they had to stop it because his blood pressure dropped drastically, and he was in severe pain, and he was in dopamine like 20 for 24 hours. Okay. So at that point, I asked for palliative care consult, or at least something to see if it's a mild heart attack, why do we need to go so aggressively? And even though I asked for that on his behalf, or his wife's behalf, actually, the doctors were already, the ICU doctors were already deciding that he was going to go for the same procedure the next day. And they were reassuring him that this is a safe process. Technology is much better now than 20 years ago. And I'm like, yes, technology is better, but your body is not. Your body is 20 years older. You have more medical problems. And, I had a conversation with him, and he's like, the doctors really reassured me. And I'm like, I called the doctor actually. And I said, did you have an interpreter with him? Because his English isn't that great. And he's like, oh, I'm not the person who does that. And he's like, that's his consent. He agreed to that. I'm like, yeah, he agreed, but does he understand?
It's not informed consent.
Exactly. And that's what I was asking for, like a palliative care consult to see what other options he has. And
it is your right, if you are the designated person on DPOA for health, then you can request a palliative care consult.
Yeah.
And you can reasonably forcefully say, I want that before you go to the operating room.
Yeah. Well, his wife was, and still, because I think because of Omicron as well, like people were not allowed to physically be there, which made it harder. You know, in the past, he was in the ICU and we advocated on his behalf and things went less aggressively. But yeah, advocacy. Mhm.
Basically, I want, because I have other hands up, I want people to understand that palliative care is not hospice.
Mhm.
It does not have the restrictions of you can't have any life-sustaining treatment.
Mhm.
It is exactly the quality of life
Mhm.
that is being addressed. And no one can prevent you from getting a palliative care consult, assuming that they're available in whatever system you are. And to the best of my knowledge, there are palliative care physicians in every medical system,
Yes.
at least in the Bay Area.
Yes. Yes. Thank you.
I need to go on there. Crystal?
Thank you.
Yeah, I just wanted to ask you on the same lines of advance directives. I was hoping to ask you from a physician's point of view about the End of Life Option Act. And I find working in hospice all the time that when I have a patient that has decided they'd like to go that route, you know, they're educated, it's almost always someone who is a doctor or has had that education themselves. But I still find there are a lot of physicians that aren't comfortable signing off on that. And I was just kind of wondering
I'm sorry, there are physicians who are or are not
comfortable. So the physicians will say, I will be the second doctor, but they don't want to be the first to sign off. So I'm wondering how much education in your realm that you see for physicians about this.
Not enough. I mean, the basic, not enough, excuse me, information. And actually one of my best friends from grammar school, who's a physician in Washington State, does these consultations. And there are people who are known, particularly if you're in the hospice world, they know who will be willing to, as a consult, give the primary okay. And then if the attending physician, the person who's treating the patient, can do this second one. And the second one is basically simply to verify that that person is compos mentis, that they're not depressed and they're not in delirium. So it's a usable, and physicians have their own ethical standards. And I would never ask a physician to do something that by their reckoning was unethical. You don't want a doctor who's willing to do that.
Oh, for sure. For sure. Do you think that sometimes that question comes from lack of knowledge versus feeling bad about it?
Yeah, I'm certain that more education, which I've actually tried to do at El Camino Hospital, would be useful.
Thank you.
Angela?
Thank you. I appreciate all of this information. And earlier when you were talking about sort of pulse and advanced directives and whether or not they're on file at the hospitals, it made me think of a client that I had when I was working as a medical social worker still last year at Eden Medical Center. And we had a 95-year-old come in who was non-responsive, and we did not have anything on file. And so they did start doing chest compressions and attempting to resuscitate her. And her 96-year-old husband shuffled in with their 75, 76-year-old son to let us know that no, in fact, she was a DNR. And we ended up stopping that resuscitation process. But a lot of that could have been alleviated by just having that paperwork on file, and none of it was on file. And they had no mortuary and no final arrangements made at that point in time. They'd had discussions, but nothing was in place. So just really emphasizing the importance of having that paperwork on file, having the post on the fridge or behind the front door at that residence, you know, when the EMTs come into the room, and how important that documentation is once they get to the hospital, because if none of that is on file, they will assume that the patient is full code and they will do what is needed to be done to try to keep them alive and stable until somebody else can tell them otherwise.
The answer is yes to both the need for making visible your wishes, and visible to the people who will be in charge of whatever needs to be done after you've died. And yes, the physicians are by law in the ER required to stabilize a patient if there is no other guidance. As you noticed, they were able to stop and withdraw the life support when given a reasonable, valid person giving the request, the husband and the son. So doctors will go with the spoken requests when it seems obvious. And there's some doctors who are more persuadable than others. Wesley?
Yeah, so I come from a slightly different angle in my experience. I was a grief counselor at Clara, where you all spoke before. And in my experience, a lot of times when people are faced with that situation, you know, we're still in the shock part of the grief cycle, the shock and anger and denial. So it's really hard to make logical decisions, even when you've got that piece of paper in front of you. And what people need, whether it's the patient or whether it's the loved ones, more often it's the loved ones, is time. And sometimes they're like, I just need a bit of time. Can you just give me a bit of time to kind of get through a very compressed, you know, shock, anger, denial phase of the grief cycle before they can think more logically about this? And is there, and a lot of times in a hospital, you know, you're under a ton of pressure to make those decisions fast. So what is your thought about, we just need a bit of time, and it could be a few days to get to a point where we're thinking more clearly about this?
The essence of strategy of any kind is timing. And the wise decision is simply what is appropriate. And the inability for a person to be clear enough headed at that moment to make critical decisions means that it's not appropriate. So you support that person. You have other trusted persons. Again, if there's no trust relationship set up between you and the client or patient, then it's a tough road. But if you can empty yourself of any of your agenda, people know that this is a person who is totally open and they can be vulnerable. So in fact, there's a word, kenosis, which is not an illness. It's not something like psoriasis, but it means to empty oneself, literally of self, so that there is only a space into which that person can speak and be heard. And in terms of what would be appropriate for anyone who's dealing with people who may be end of life or approaching it, is that openness when you're there speaking with them. It takes a little bit longer at first, but avoids a lot of lengthy problems later. Renata?
Hi,
By
yes.
the way, are you in a parents group?
Parents group? No, my not right now.
Because my daughter, I think, was in a or is in a group, and your name came up.
Oh, okay. Well, it's not a very common name, but it's probably a different Renata, since my kids are over 21 now. So.
Oh, actually, it was Spangler.
Oh, the Spangler part of it. Oh, okay. Usually people think I'm associated with the mortuary. Oh, I don't know. No, I'm not in any group that I know of right now.
Your question.
Okay, so, I just want to thank you so much and let you know how much I appreciate you as an oncologist and all of you. I don't know if you can hear me so well, because this is just highly coincidental that yesterday I was actually in the room with an oncologist and one of my best friends. And he so kindly, presented to my friend her options as he's realizing that, the chemo's kind of at the end of the helping phase, but he gave her that option. He said, would you like to, just continue with some drips, albumin, or would you like to just go home and not have to keep coming in for infusions? And it was interesting. Or would you like to try another chemo, which he knew, I think, very well, that was just going to be a Band-Aid. But he gave her that option. And she said, the comfort of she caught it right away. And she said, well, that sounds like giving up. The option of, well, would you like to just go home and not have to bother coming in and just be comfortable? So it was just incredible to be there in the room and see the empowerment, as you mentioned, to give to the patient, to say, that sounds like giving up and I'm not ready to give up. Even though, deep down inside, she knows, I'm sure, that she's failing. And the doctor knows and everyone else knows, but then it's just like letting her be able to run the course and someone else making that decision. So I want to let you know how much I appreciate. Wow, what a job you guys have as oncologists, and have to have those conversations with people. And again, how, not taking that power away from somebody, how valuable that is. So thank you.
You are a good friend indeed to this person.
Well, thank you. Well, the husband was, could have been on the phone, could have been there, and kind of knew that conversation was going to be there. But he didn't want to be there for that. So it was interesting. So that was okay to be there as the person. Yeah.
Never go alone into a doctor's visit.
Well, with COVID, it's been very tricky with this situation for this family.
Or record the conversation.
Yeah.
No doctor will object to that, particularly when I know you're saying really important things to me, but I want to remember them. And so may I record this conversation?
That's very interesting, because I said to the husband, I said, gosh, I feel like, because he kind of gave me a warning going in. He says the doctor may say that, look, this isn't going to keep working for her, the chemo. And I said, gee, maybe I should figure out a way to record it. And he said, oh no, the doctor doesn't want to be recorded. But so I guess I could, now I know, and I could have asked, but it was pretty simple information that could easily, that the husband's going to get in the notes as well. But yeah, I see what you're saying. Yeah.
Because the tone of the doctor's commentary is often what is being communicated, not just the words.
I see.
Mm.
Right, I know.
That's true with all of us.
Yeah, yeah. And I was just so very impressed at how he presented, this information and how he just openly accepted her choice and, went with it in a positive and, it was great. It was amazing. So anyway, I want to thank you.
You're welcome.
Yeah.
Okay, we need to wrap up, but Noah, you had your hand up. So why don't we make that the last question, please?
Okay, thank you. And thank you, Renata, for your valuable sharing. And you presented the doctor saying, would you like chemotherapy as an option? And on the flip side, the other side of that is last year, my 92-year-old dad went to the emergency room with pneumonia. And then a week later, he didn't do better. So we went back again to the emergency room, and then he was diagnosed with lung cancer. And so he was 9 pounds. And what the emergency doctor presented to me is like, would you like a referral to an oncologist? I'm like, nobody's touching him. So I contacted hospice immediately, and he died within less than a month. So there's two sides, presenting chemo or oncology as an option, and the patient decides. And what happens when the patient doesn't really get it? Because I've also seen some of my patients receiving chemotherapy till the very last day of their lives, which is really cool. So you get both sides. Thank you.
I guess that was a comment more than a question for Bill. Okay, great. Bill, any last words before we wrap up?
That's not a phrase that you want to say when you're talking about end of life. Any last words?
Oh,
Sorry, not for the meeting.
I've been talking long enough, and and again, you have my cell phone and my email. So if there are other questions that you have, please contact me.
Thank you, Dr. Bill, for I have so many comments that came to me directly about how much they really appreciate. I'm sure there'll be more questions once I send out your advanced directive, Appendix B, and the other things. Why don't we go ahead and stop the recording, Shauna, and then let's do a quick set of announcements.